Welcome to the Prevent the Preventable podcast, where we're on a mission to change the landscape of brain hemorrhages by driving awareness, delivering education, and pushing for real action. Now, brain hemorrhages affect millions of lives every single year. But at the Natalie Kate Moss Trust, we're committed to preventing them before they happen and funding pioneering research to advance treatment for when they do. In this podcast, we'll dive deeper into the world of brain hemorrhages because the more we understand, the more we can create real change, and together we can truly prevent the preventable. Hello and welcome back to the Prevent the Preventable podcast. I'm your host, Fiona Moss, director of the Natalie Kate Moss Trust, and I'm genuinely thrilled to be kicking off another series with you. Our mission at NKMT is to save more lives by better preventing and treating brain hemorrhages. And starting this podcast has been a pivotal step in raising awareness about the reality of brain hemorrhages and in bringing our prevention campaign to more people than ever before. This in itself is so important because the more we talk about brain hemorrhages, the more we understand them, the more we can drive real, tangible change. From funding groundbreaking research into life-saving treatments to preventing more cases from happening in the first place. In Series 1, we opened up some incredibly important conversations. We heard moving stories from survivors and families. We explored what it's like to experience a brain hemorrhage and spoke with leading researchers, clinicians, and campaigners. From recognizing early warning signs to understanding the role of high blood pressure to hearing how families begin to rebuild after sudden loss. It was raw, it was honest, it was emotional, and it was deeply informative. Before we go any further, I just want to say a huge thank you to Hugh James Solicitors at Colony Co-working, sponsors of both Series 1 and now Series 2. Your support means that through this podcast, we can help spread these critical messages even further, helping us create real change in the landscape of brain hemorrhages and ultimately saving more lives. So thank you. And if you're keen to understand how your company can be involved in future episodes and support this vital work further, please do reach out to me via the link in the show notes. Outside the podcast, it's been an incredibly busy and inspiring year for the Natalie Kate Moss Trust. We've grown our team, pledged another £300,000 to the research at the University of Manchester, checked hundreds of people's blood pressure, delivered countless awareness days and lunch and learn sessions in companies, and cheered on dozens of incredible fundraisers. So much progress, and it's all thanks to you, our amazing supporters. Your donations and time and belief in our mission are helping change the future of brain hemorrhages. And to see just how far we've come, please do head to our website and check out our latest end-of-year report. Now, if you've been here with us since Series 1, thank you. And thank you for returning. And if you're new here, welcome. You're exactly in the right place. This podcast, brought to you by the Natalie Kate Moss Trust, is all about raising awareness of brain hemorrhages, championing prevention, and supporting those whose lives have been turned upside down by something so sudden and so devastating. If you haven't already listened to Series 1, I really encourage you to go back and start there, as there is so much helpful information for you to get your teeth into. But now, with Series 2, we're going even deeper, with more expert insight, more lived experiences, more guidance from those who are navigating a life post-brain hemorrhage, more support for loved ones, and more tools and resources to help us all better understand how we can prevent potentially preventable brain hemorrhages. Because the devastation caused by brain hemorrhages should not be happening at the scale it is today. And that is the basis of our work, to lessen that impact. But to truly make change, we need to look at the bigger picture. And that's exactly where we're starting in today's episode. So today we're looking at brain hemorrhages through the lens of data. And that might sound a bit clinical, but actually it's deeply human. Because let's be honest, behind every number is a life affected. Someone who collapsed at work, someone who didn't make it to the hospital in time, someone who's learning how to walk or talk again, someone who's still here, and someone who isn't. We'll be asking questions like, who is really at risk of a brain hemorrhage? How many people in the UK suffer a brain hemorrhage every year? What's the survival rate? Does your postcode, income, or ethnicity affect how quickly you get diagnosed or how well you recover? And most importantly, how many cases are preventable? And what can we be doing to prevent them? Joining me today is someone truly exceptional, Professor Stuart Allan. Stuart is a professor of neuroscience at the University of Manchester and was instrumental in establishing the partnership between NKMT and the university. He is also one of the founding figures behind the Jefferson Brain Research Centre, a renowned centre of excellence in brain research here in Manchester. Stuart has been the driving force behind intracerebral hemorrhage research in Manchester, and it's thanks to his leadership and vision that this area of work has expanded so significantly over the past 13 years since the inception of our partnership with the university. Quite simply, I believe we wouldn't be here where we are today as a charity or in terms of the progress in the research at the University of Manchester without his dedication and commitment. Stuart's passion for changing the landscape of brain hemorrhage research is both inspiring and infectious, and I have no doubt that you'll sense that for yourself today. In this episode, Stuart will help to answer all of these questions for us, not to overwhelm you, but to educate and empower you. Because in truth, the more we understand, the more we can act. So whether you're listening as a survivor, a supporter, a healthcare professional, or someone just wanting to make a difference, today's episode is about deepening your understanding of brain hemorrhages, because we all know that knowledge is power. So let's jump in to the facts, the figures, and to the future of preventing the preventable. Morning, Stuart.
Morning.
Thank you so much for being here. So I've already introduced you briefly in the introduction to the episode, and explain more about your involvement in the trust, but also your work at the Manchester University and how sort of pivotal you've been in the growth of that as well. And today we're going to dive into everything around brain hemorrhages, their causes, the risks, who is at risk, what can we do to prevent them. But before we do all of that, can we take a step back and understand a little bit more about your career journey and what's led you to this point and working in this field of brain hemorrhages?
Yep, of course. Yeah, delighted to do so. So I've my background, I guess, is I did an undergraduate degree way back in the 1980s up in Dundee University, where I studied pharmacology, which is effectively the study of drugs in the body and how drugs act in the body. So that was my first introduction to science, and really I became hooked during that in terms of what that science was fascinating to me. And then I moved to Aberdeen. So I moved north to Aberdeen to complete a PhD, which is a focused 3-year period of research on a certain topic. And my PhD was on something very different to brain hemorrhages. I studied basically learning and memory and the processes in the brain. And I enjoyed my PhD, I had a great time, but I just felt it wasn't close enough to clinical patients and health. I always began to develop this passion really that I wanted to do. Well, research I did had to have some impact potentially on people's lives and treatment for diseases. So I moved to Manchester then in the early 90s, over 30 years ago, where I joined a group led then by Nancy Rothwell, obviously ex-president of the university. And her group was really doing groundbreaking work in terms of inflammation, but inflammation in the brain. And this was really quite unique at the time in the early 90s, because inflammation, of course, we have known for decades that inflammation is important to fight infection, etc. But the actual fact that inflammation happened in the brain was really not well studied. So Nancy's group led the way on that. And actually that was focused around stroke. The research really was focused around the fact that if somebody has a brain injury, i.e. caused by stroke, which is caused by either a bleed or a clot in the brain, we showed in our group and others in the world that actually inflammation happens, that there's an inflammatory response to that stroke. So that was a starting point really that got me involved in research on stroke and inflammation. And then I stayed with Nancy for a number of years as a postdoctoral researcher, and then I was lucky enough to get my own lectureship and then develop my own research and build the group over the subsequent many years actually.
Yeah. I think, the brain is quite complex, as obviously I don't think anyone would disagree with that. And when you will talk about different information, it sounds straightforward, right? Things like that you can kind of understand. But what I found interesting or understandable, to be fair, is that a lot of people will come to us around that maybe have lost somebody to a brain hemorrhage or have had some sort of experience with that. And what they found difficult is understanding what's actually happened, because when somebody has a brain hemorrhage, and I was the same, you hear these terms, AVM, aneurysm, hemorrhagic stroke, is that the same as a brain hemorrhage? Bleed on the brain, is that the same? And I think it can be quite confusing. So to make it really simple for those listening, could you help us just understand what exactly is a brain hemorrhage?
Yep, of course. And I completely understand, the terminology. Scientists aren't always the best at using terminology. The way I think about this in the simplest way I can explain it is that the brain is complex. There's no question. The brain is probably the most complex thing on the planet, comprised of billions of cells. Okay, so the complexity is without doubt. But actually, it's very simple in the fact that the brain has all these cells that work together and allow the brain to function and do what it does every day. It can only do that with blood. So that the brain is absolutely critically dependent on a blood supply. And that blood supply is provided by blood vessels, obviously, which I think everyone would understand the concept of a blood vessel, an artery or a vein. So that flow of blood to the brain is critical. So without blood, the brain will just stop working, full stop. And a hemorrhage is basically a rupture of one of these blood vessels. So one of the blood vessels that supply the brain bursts open and bleeds. And that's a hemorrhage. That's a term hemorrhage for any bleeding in the body. And it's called obviously brain hemorrhage because it's in the brain. And the terminology is, in the different terminologies like aneurysms, AVMs are just different types of hemorrhage that are caused for different reasons. So in the simplest terms, it's the bleeding of a vessel in the brain, i.e. if you imagine the brain tissue itself, the whole brain, so deep in the brain, a blood vessel will rupture, or around the brain. So the brain's surface is covered in blood vessels as well. So a blood vessel can obviously rupture in the brain tissue, as we call it, or it can rupture around the outside of the brain. And these are different types of stroke, basically. So we refer to intracerebral means within the brain, and that is intracerebral hemorrhage. So that refers to a blood vessel rupturing deep in the brain. Subarachnoid, so the arachnoid is a lining that covers the surface of the brain. And basically all that refers to is the anatomy of where it is. The blood vessels run under that arachnoid layer. So therefore it's called subarachnoid hemorrhage, i.e. there's a bleed in that layer.
Yeah.
And that's quite different because obviously a bleed in the brain, if you can imagine blood's leaking into the brain tissue itself, whereas if a subarachnoid hemorrhage happens, the blood's round the surface of the brain. So actually the consequences are similar in terms of mortality, etc., but in death, but obviously the causes are different.
And what would cause an intracerebral hemorrhage?
Versus a subarachnoid hemorrhage. So the causes are so if we take subarachnoid hemorrhage firstly, which is a bleed round the brain. So typically that's caused by what we call aneurysms.
Okay. So
an aneurysm is a bulge. If you can imagine a small balloon-like structure on a blood vessel. So for some reason, sometimes hereditary, although that's rare, small bulges develop on arteries around the surface of the brain.
Can we explain them? As in, can you explain why they'd happen, or is it just one of those things?
So they happen because of increased pressure. So hypertension is a risk for that. Anything which weakens blood vessels. So there are some conditions that tissue connect. We call them tissue connective disorders, which can mean the blood vessels in the surrounding tissue aren't as strong as they should be. So there's weaknesses, and these tend to form these aneurysms or bulges tend to happen at points. Because if you can imagine the blood vessels, they don't just all run in straight lines like train tracks. They have junctions. So blood vessels will come in and they'll form two separate arteries that go off. These junctions are weak points because you get blood flow that effectively, we call it turbulence. Okay, the blood flow there is not linear, so it flows in a circular motion, and that causes stress on that bit of the vessel. So if you have stress, just as if you're in a pipe, that pipe becomes vulnerable, and if the vessel itself has got a potential to weaken, it will form this bulge basically. And it's the same as if you've got a garden hose pipe that's got a weak part, it'll start to bulge. So it's very similar, to be honest. And that bulge then sits there. And actually, for many people, they have them. So many people will have these. They're quite common, but actually with no problem whatsoever. They don't even know they've got them. Actually, detection's only increasing because people are getting brain scans more often, and you can then see them. But actually, for many people, they're not a problem at all. But obviously, it's unfortunate for some people, if they get big, they burst open, and they effectively burst, and that's the rupture of the vessel. Yeah. So that's typically the cause of subarachnoid hemorrhage. Intracerebral hemorrhage is different because obviously that's deep in the brain tissue itself. But actually, the underlying reason you get a blood vessel rupture is similar in that the vessel becomes weaker. It's not as strong as it should be. Age for both is a big factor. Okay, that you cannot get away from the fact that as you age, clearly the vessels become older, as the rest of the body becomes older, they become weaker, and that therefore is an increased risk. So age is the biggest risk factor. Of course, we can't change our age, although maybe in future science might do that, but we can't change our age. That's not modifiable. We talk about modifiable risk factors. But for intracerebral hemorrhage, if you, and I've talked about this already, if you've got a pipe with fluid flowing through it, if you increase the pressure within that pipe, it puts greater strain on the walls. And that's effectively what happens in intracerebral hemorrhage. The more strain and pressure you put on the walls, the more chance of a rupture. And that's why blood pressure. So your blood pressure is obviously the power, the force that forces the blood around the body. And if that's high, i.e. hypertension, then the risk is higher.
Yeah.
So the single modifiable, the single biggest modifiable, the biggest modifiable risk factor is blood pressure.
Yeah, I think that's such a good analogy. I've used that. I think I was told that maybe one of you guys told me that sort of analogy once upon a time, and I think it's something that people can relate to. And I think it then makes sense. When we talk about these terms, as I said earlier, it can get really confusing. So how can we make it a little bit more relatable in some ways? And I think this idea of, they are pipes.
Yeah.
And actually, if there's too much pressure going through a pipe, there'll be a leak, or there could be a leak here and there. And it's that leak that we're, worried about. And if there's too much pressure, that's, it's more likely to leak. So I think, that is so helpful for people to understand. Well, I know that I found it helpful. And I'm sure so many other people find that helpful too. But if we just go back to that point around aneurysms, because we did actually have an episode in series 1 with a charity called Hereditary Brain Aneurysms, HBA, and they work on helping people to understand if they have an aneurysm because maybe their mum did and their grandma did and their auntie did, and they've all then subsequently had a brain hemorrhage, and picking up and detecting aneurysms early so that it can be managed, or maybe they have surgery to coil it, but understanding a little bit more around that, maybe like aneurysms. Is it something that if somebody's listening to this, and the majority of people that are going to be listening to this probably will have had some sort of experience with brain hemorrhage, a family member or something, and I'm sure a number of them would have had an aneurysm as well. Is that something that then can be managed? What is it, something they should worry about? Is it hereditary? Can we explore aneurysms a little bit more?
No, absolutely. I'm not an expert. I have to be, put a cautionary note on it. I'm not a clinician and work on aneurysms, but certainly I can explain some of the in simple terms, I guess. So aneurysms are not, the majority are not hereditary. So probably about 10 to 20% are hereditary, or some genetic link to that. You've mentioned it already, Fiona. If you have a history in your family of first degree relatives, i.e. parents, etc., siblings, relations that have had hemorrhages, a bleed, subarachnoid hemorrhage, or an aneurysm, and particularly in multiple locations, that there's a stronger risk, that there's a potential there that you do have increased risk. It doesn't mean you're going to have it 100%. Okay, it's not an absolute guarantee you'll have it, but obviously the risk is higher. So obviously, in that situation, and it's difficult. The management is no question. It's difficult because it's the moment as it stands at the moment, we have no actual cure, so we can't cure it as in stop them happening. Obviously, that would need a lot of research, and that would need us to understand what the trigger in the first place is. And of course, if it's a genetic cause or some gene, that's quite challenging to discover what's happening. But of course, science advances very quickly, so we're able to do that. So the reality is, if you have it, then obviously, if you're at high risk, you would have a brain scan, which would confirm if you have them present or not. And then it's a case of monitoring and management in consultation with the specialist. And the decision would be taken on the basis of the risk. So if they're big, okay, so and size is important here, okay, because and it's like having a fluid-filled balloon. When I was a kid, I always had water balloons that you use. If you filled it with a small amount of water, it would never, and threw it at somebody, it would never burst. If you fill it full, it would burst, and that's just the same as an aneurysm on a vessel. So if they're big, they will do something about it because the risk is high, and that would, and you've mentioned it already. Neurosurgeries now, they would either typically we call it coiling it, which is an amazing surgery where they advance basically I can't remember the material, I think it might be titanium, or they put metal, very small fine metal, through your artery in your leg and advance it all the way up, believe it or not, into the brain to fill that bubble with metal, so then it's just the risk of rupture. Or they clip them In some cases, they can't do that, and that would require brain surgery, where they open up the skull, get access to the aneurysm, and they would basically put a clip across the bottom of it and seal it off. And that's except that management, it works. I mean, obviously there's a surgery and there's a risk, as in any, particularly with anything in the brain, there's risk, but it can basically prevent them bleeding.
Yeah.
The reality is, smaller ones, they won't do that because of the risk benefit. Okay, because if actually they think on balance that's not going to rupture, then we'll leave it. But of course, for any individual living with that, one of my clinician colleagues, it's like having a ticking time bomb in the brain. Okay, and that's not easy to live with, I guess. And so I guess there's some element of managing and living with that and having, but I think the awareness of actually the risk is low, then it hopefully helps. But research hopefully will allow us to understand a bit more how to stop that happening.
I think education is, and I touched on this in the intro, is that education really is kind of power. Knowledge is power, because the more we can understand, and the more somebody can explain something to us about the risks and, the benefits, it does put your mind at ease. I've spoken to a number of people. We definitely had an episode in series 1 where a gentleman had lost his mum, and he spoke about how he was really anxious after it. Every time he got a headache, he was worried. Am I having a brain hemorrhage, or am I at risk, or is there something going on? I've certainly kind of experienced that at times as well. And I think then if you're told you actually have an aneurysm, but to be honest, we probably don't want to do anything about it, we want to just leave it, I'm sure that level of anxiety is quite high. But I think, the more research we do, and, all the work that you guys are doing at the University of Manchester and with the Geoffrey Jefferson Brain Research Centre is kind of helping us move this forward. To your point, there's not necessarily an opportunity for us to kind of, necessarily dissolve those aneurysms or understand why they've happened, etc. But that hopefully will come the more research we put into this space as well. So I think what would be helpful kind of is to understand the scale of this problem. I think when Natalie had her brain hemorrhage, I mean, I was 20. I wasn't a child, but I was, kind of, I guess I was still running around university, but, having fun. And, but you don't hear about them as much, even though I know that they're very common. Yeah. But what is the size of the problem? What's the scale of the problem? How many people worldwide, firstly, have a brain hemorrhage, but then also in the UK as well?
Yep. So yeah, you have to, and that's I think it's a really important point, is how, because when people use the term common, but what does that actually mean? It is common. So I guess to put numbers on it, because obviously these numbers are collected, and numbers the data is getting better and better, obviously as technology advances. So in the UK, if we take the UK figures, so in the UK annually, so each year, around about 150,000 people will experience a stroke. So the incidence, basically, that's what the term would be used. The incidence of stroke is around about 150,000 people per year. Okay, which is obviously is a significant number. That's twice Old Trafford, right? So if you can imagine, on any Saturday that's full, that's twice the stadium in 1 year will have a stroke. In terms of hemorrhage, and obviously I've mentioned already ischemic stroke. So ischemic stroke is the most common by far. So about 85% of strokes are clogged in the brain, and that's quite different and managed very differently to hemorrhage. So in terms of brain hemorrhage, whether that be the bleed inside the brain or around the brain, the incidence is 15%. So if you do your maths or your arithmetic, so that's about 22,500, 25,000 people per year will have a brain hemorrhage. So that sounds a lot, okay, and that's of course significant. But just to put it into context with other conditions, and I thought about this before I came in. If you consider, so what's used in terms of epidemiology is the number of cases per 100,000 years. So if you've got every 100,000 people, how many people will have that condition? So for brain hemorrhage, it's about 30 per 100,000 will have it. Which actually, if you put that again into context, if you have a full stadium, so for example, I'm a big rugby fan, the British Lions were recently played at the Melbourne Cricket Ground. The capacity of that stadium is 100,000 people, right? So that means in that stadium, if you just thought for that 1 year, we have 100,000 people sitting there, 30 of that stadium will have a brain hemorrhage, okay? Which actually is a relatively small number. If you compare that to Alzheimer's disease, okay? So Alzheimer's, and of course they're different, very different, although they're both diseases of aging largely. So Alzheimer's disease incidence is about 500 to 800 people per 100,000. so about 20 to 30 times higher. So that's to put it into context. Another condition, obviously, which is devastating in terms of effect on people is brain tumours. So brain tumour incidence in the UK is about 20 per 100,000, so comparable to hemorrhage. So that's the sort of incidence in terms of what we're talking about. If you look globally, and of course, we are a global society now, unfortunately, actually, the rate of hemorrhage, the incidence of hemorrhage is much higher globally. So it's about 28%. So rather than 15% of strokes, globally it's about 28%. So it's moving towards a third. And if you put that in, if you consider the global population, that means about 3.4 million people have a hemorrhage each year in the world. And the reason why that is because some of the risks for hemorrhage are higher in some parts of the world, particularly in Asian populations and some areas of Africa. There's quite high incidence of hypertension and high blood pressure, and therefore the risk's higher. And potentially genetic causes as well,
Yeah. So it really does show that, high blood pressure, hypertension
Absolutely.
has such a major impact.
Yeah. And the biggest, there's areas of Asia which, where they have preserved foods. So if you look at some societies which are nomadic and therefore use salt an awful lot to preserve the food, the incidence is very, very high. Yeah. Because hypertension is very high in that population because they have a very high salt intake.
Yeah. And obviously there's many causes or factors that contribute to high blood pressure. Adam and I spoke about that in one of the episodes in series 1 as well. And but I think it just shows that lifestyle, what you eat, how you live, plays such an important part. And I think that's what we try to do with the podcast, is join the dots for people and go, okay, well, it's not just your lifestyle, it's also your lifestyle that contributes to high blood pressure. And it's not just blood pressure, it's what that blood pressure potentially has the potential to cause as well. So it's drawing those dots for people. And as I said earlier, it's about giving them the information, it's about that knowledge piece, because then they can go away and kind of make adjustments to their own life as well. But I think those statistics are really helpful. And I think actually, that view of what it looks like in terms of whether a stadium or the percentage of a stadium, I think again it's relatable for people. But of those number of people that have a brain hemorrhage every year, what's the survival rate like?
Yeah, so that's where the stats are really poor, and that survival is quite low. And what the stats are, the hard stats are that of every 10 people that will have a hemorrhage, then 4 of these people will die within a month. So mortality, as we call it, is 40%, about 40%. It's different databases, you have different figures, but by and large, it's around 4 in 10 people will die from that hemorrhage within 1 month. So the fatality rate is high. If you compare that to ischemic stroke, so where we have a clot, ischemic stroke, the mortality rate is just over 10%. So actually, it's quite a lot lower. And the reason for that is, there's several reasons actually. But one of the main reasons now is we have actually quite good treatments for ischemic stroke, whereas we don't have any very good treatments for hemorrhage. And also the nature of what happens in terms of bleeding in the brain, etc., tends to be severe. So much, sadly, mortality is high. So although you could say incidence is not as great as some conditions, actually the mortality is very high. So of course that impact on families is enormous, particularly as it's a sudden onset condition. This is not something people are prepared for. So it's a sudden onset, and it can happen, as you experience yourself very sadly. It can happen actually across, although age is one of the biggest risk factors, it can happen across all ages. So mortality is high, and that's true of subarachnoid hemorrhage or intracerebral hemorrhage. The mortality rates are roughly comparable. And also, what's really really unfortunate is actually that statistic has not actually changed that much over the last few decades, which is really quite worrying in some ways, given how much advance we've made in other conditions. I've just mentioned ischemic stroke. Ischemic stroke 20 so years ago, the survival rate was probably, or mortality rate was probably getting closer to 30%. But yeah, now it's going down because of the improved treatment and awareness as well. You mentioned awareness. People are very aware of the symptoms of stroke and ischemic stroke. Typically, obviously, there's the FAST campaign was launched many years ago, and people are much more aware now that actually if you have facial weakness and arm weakness and slurred speech, then that strongly suggests you may be having a stroke, get to hospital. hemorrhage can cause the same symptomology, but sometimes it may just be a really devastating a really profound headache. So actually it may present slightly differently. So the mortality rates, sadly, are really poor. So that needs to be changed.
Yeah. And that's something I kind of want to go on to now, but I think you're right in the same sense that, especially we talk about the age, and obviously that is a risk factor, but there are people that are younger, and I've heard this story a number of times where people have gone, they might be in their 20s, their 30s, and said, I had a really bad headache, but I just went to bed and I tried to sleep it off, because there was no other reason why they suspected they needed to get to hospital, even though it was, the worst headache of their life. And I think there's many reasons we could go into around, why brain hemorrhage isn't getting that sort of focus. But I'd love to kind of just understand a little bit more about why do you think it's not getting that focus? We've spoken about ischemic stroke, we've spoken about the FAST campaign, obviously the research has increased, but what do you think is it about, like, the brain particularly and brain hemorrhages that is just not getting the attention it deserves, so that we can advance that treatment, so we can move it forward, so that, we can reduce those statistics?
Yeah. Like, I think there's different reasons, why any one condition gets more, and I guess publicity, I don't like using the word publicity for a disease or condition, but the reality is, our awareness, and I think there, increasingly you see people more willing to talk about disease and conditions. My mum's in her late 90s, and she never talks about and has never talked about disease and conditions, because it was that generation just avoided doing that. And I think there's more openness now and more willingness for people to talk about, particularly the brain and what's happening to people's brain. And a good example, of course, is dementia. Dementia is now 20 or 30 years ago, awareness and even talking about dementia was not really that common, but now, of course, you hear about it every day. I think that there's several reasons, multiple reasons why hemorrhage might not get the, people are more aware of it compared to other conditions. One is undoubtedly the media and what's presented in the media and what the media covers. And of course, over the recent years, there's been very high profile coverage of some conditions on the media. Dementia, I've mentioned already. Dementia, rarely a week goes by that dementia is not mentioned in the media. And of course, that's rightly so. I've told you the figures. There's a significant number of people affected by dementia. It has a major impact on the individual and the families, etc. The other one is, of course, motor neuron disease, in particular of late. Incredible publicity for what is an absolutely devastating condition. And of course affects young people, and we've seen really high profile cases. And I think that high profile nature of some of these cases undoubtedly it means that the coverage is then therefore there in the media. And hemorrhage hasn't necessarily had that coverage because not necessarily so I don't want to say that celebrity is important, but actually undoubtedly if somebody is a celebrity or a well-known person and they have something, people are more aware of it because of just the very general nature. So there's that element, that whether people are willing to talk about it, the survival, people, the acute nature of the disease, I think is a major I use the word issue, that just makes a problem, but motor neuron disease, dementia, you're diagnosed with it and you're told you've got it, it's just devastating. But then you live with that for a period of time. So actually there's a period of time to discuss it and come to terms with it. Whereas in a hemorrhage, it happens in an instant. In an instant, a hemorrhage will happen. And then, as I've just said, 4 out of 10 people will die. So actually a significant number of people with hemorrhage die. So actually, obviously they cannot, it's left for the family and carers and loved ones to talk about it in the context of that. And survivors, those that survive, a significant number are actually quite severely disabled. And that can include problems with speech, for example, and mobility. And actually, therefore, you can imagine the willingness of that individual or capability of that individual to talk openly is difficult. Yeah. So I think there's certainly elements about hemorrhage which make it more challenging to be out there. So I think it's multifactorial. And I think also charity charities are vitally important. And of course, your own Natalie Kate Moss Trust is growing enormously and done great work in talking about hemorrhage and what it is and raising awareness. The reality is that charities have limited capability and capacity to pay for TV adverts or do whatever they do. Yeah. And of course, the reality is there's some big players in the charity world. Cancer Research UK is enormous and have phenomenal advertising capability. So therefore people are more aware because actually it's just, it's more publicized, if I'm honest.
Yeah. Hi. I won't take up too much of your time, but if you're listening, it's probably because you care about making a difference. And the truth is, we couldn't do any of this without you. Whether you've run a race, come to one of our events, whether you donate regularly, or have made a gift to us in your will, thank you. You're helping to fund life-saving research into brain hemorrhage treatment. Now, just £33.91 pays for 1 hour of research at the University of Manchester. That's 1 hour closer to improving survival rates and reducing long-term disability for thousands of people. And here's the thing. Every pound makes a difference. In fact, if everyone who interacted with Series 1 of the podcast, whether by listening to it or downloading an episode, watching a YouTube clip, or one of our reels on Instagram, if all of those people donated just £1, we could fund half a year of research. And if you'd like to help, the link to donate is in the show notes. And it goes without saying, thank you for helping us save lives from brain hemorrhage. Now back to the episode. I completely agree with everything you've just said. I don't know whether you've ever had that conversation, but everything you were saying is the theory that I have around, why I don't think that brain hemorrhage gets the, I don't know, it's not the headline. It doesn't get in front of people in the way that it necessarily deserves to. And I think you're totally right. I think brain hemorrhages are so devastating. They happen. There's a line in the sand. It's like a schism in time where it just says there's a before they had a brain hemorrhage and there's an after they had a brain hemorrhage. And particularly if that person unfortunately passes away, or even if, as you say, they survive, but they're unfortunately severely disabled. I think for them people to think, okay, well, we need to straight away get on and be raising awareness, and they've got their own, challenges to face, whether it's grief, whether it's looking after that person, and they're trying to come to terms with it as well. To your point, whether it's breast cancer, whether it's, different types of cancer, whether it's MND or whatever it is, if you've got that diagnosis period, you can kind of rally your troops. Everyone gets behind you. You do something for it. But I do think the celebrity element, does help. I think it's in a really good way. I think it's amazing that MND has had the growth that it's seen over the last, I don't know what it's been now, maybe 4 or 5 years, because it's really helped. It's given a voice to a condition that probably people might not have wanted to speak about before because it was, one, complicated. They might not have understood it, but it affects so many people. Just as, we talked about before, brain hemorrhage affects so many people too, as well as their families and their friends. And so I think conversations like this, the work that we're doing, trying to get in front of people, talking about it, normalizing it as much as possible, not making it a taboo subject is so incredibly important as well. And hopefully when charities do this, when celebrities talk about conditions, it then gives other people who've maybe been through it permission to talk about it with their friends, etc. And it's a snowball effect in a way. But I think without those conversations, we don't move forward, and I think people can be scared, to your point about your mum. I think if we're too scared to talk about things, we're then not going to be doing the work to get behind it, to advance the research, to move treatment forward, etc. And so things are just going to stay the same, in order for us to, or we talk about changing the landscape of brain hemorrhages. In order to do that, we need to talk about it more as well. I'd love to maybe just touch on that point then as well around the Jefferson Brain Research Centre, which you were sort of instrumental in sort of setting up as well. Can you explain what it is, why you set it up, and sort of the work that you're doing there?
Yeah, no, absolutely happy to do so. Research, I mentioned earlier on when you asked right at the start, I've been in research for 30 years. Research, I think actually, and I use the word blame, but I think researchers and universities themselves probably don't do as good a job as they could in terms of talking about and promoting the fact that universities are, of course, a learning environment, and everyone knows that students go to study, but actually most universities also have significant research focus and interest, and that's true in Manchester. Manchester has an incredible research profile across all different areas of the university. And in terms of neuroscience itself, so neuroscience is, of course, the study of the brain, which therefore covers, how the brain works just fundamentally. And there's lots of research just trying to understand how the brain works and what it does. And of course, disease. And we're talking here about brain hemorrhage. We've mentioned motor neuron disease. We've talked about dementia. Of course, there's many conditions which affect the brain. And in fact, probably the biggest, impact on society, particularly moving forward, is probably going to be brain health. Conditions which affect the brain, whether that be what we call neurodegenerative disease, i.e. where the brain sadly begins to die and bits don't work, such as in dementia, Parkinson's disease, or mental illness. And of course, we know that there's a significant concern in society around the number of particularly young people affected by mental health, which of course is the brain and how the brain works. So we, several years ago, I was aware at the university there was lots of great work going on in neuroscience, but it was relatively I wouldn't say, I use the word invisible, but it was known to the science community. So of course, you work in your little bubble that we work in science. We go to meetings, we talk about what we do, we publish our work, and we report what we've done. But it tends to remain within that, small scientific community, which many things do. But it felt that there was no focus, and actually there was no identity to say, well, actually this is what Manchester's doing and why we're doing it. So it was really around, an idea to basically bring a focus to research in Manchester, particularly research in Manchester, where we're trying to do what we're doing in brain hemorrhages, is actually improve outcomes for patients and ideally, of course, cure and prevent things happening in the first place. In reality, I think that's a long way off till we can completely cure these conditions, but at least then manage them better, such that survival's better, people are less disabled, and then therefore have better quality of life. And so that translation of the great science that's happening through to actually making a difference to patients. And that's why we set up the centre. And at the moment, it's what I call a virtual centre. We have no physical building. Those people that will live in Manchester will know, of course, the Christie Hospital very well, which is obviously our centre for cancer. And the brand new, beautiful Patterson Institute is effectively the research centre for cancer in Manchester. We don't have the equivalent for neuroscience, but that's a dream moving forward in the future. But the Geoffrey Jefferson is a name given to bring things together. So rather than being disparate parts of the university and separate departments here or there, it's to say, well, actually, let's combine things and present it together. And it's, I use the analogy, it's like a shop window. It's saying, well, actually, this is what we're doing, and presenting it to the public and to the scientific community to say, this is what we're doing and why. And the why piece is particularly important, because, everyone will ask the question, well, why? Because we're using public money, we get grant funding, we're using charity money. Why are you doing it? And the single, the statement, our mission statement is this: the centre was established to more rapidly move things from discovery science, i.e. where we make, find out new things that are happening in the brain and might be important in a disease, to move them faster to treatments for patients, or improve care. It's not all about drugs and finding new drugs. It's, we know that actually some of the way patients are managed through the system is maybe not as efficient as it could be. And actually, can we do something to make that better, so people are seen quicker or receive things faster? So it's not necessarily all about new drugs or devices, but it could just be optimal care pathways.
Yeah, because 1% could be thousands of lives, couldn't it? 1% improved treatment could make a huge difference. And I think that's what's particularly I found fascinating about Adrian Perry-Jones's ABC bundle. Again, we spoke about it in series 1, but that isn't a new sort of medication or something new that has had to go through years of testing, etc. It is a series of steps that are just, when implemented well, when done in the right order, can significantly increase the survival rate as well. But I think, to your point, what I find interesting is that you can have research that's being done over here or on one floor, which we know has happened for you as well. Somebody's been doing research on one floor of the university, and on another floor someone's been doing research, and actually very similar, do overlap, but they don't know it's happening. Actually, if we can bring everyone together, if you bring all these great minds together, actually, you, to your point, you can rapidly improve treatment, hopefully. So I think that's what's really exciting about the development of it, and hopefully one day it will be a physical building, and we can move that forward. But it's still in its infancy, I suppose. It's only a few years old, but this is where the funds that we give to you guys and we can work together in partnership is thinking about, well, what's the long term of that? Huge thank you to Colony Co-working for continuing to support the Preventable podcast. Now, at the Natalie Kate Moss Trust, we have huge ambitions to completely change the landscape of brain hemorrhages. And whilst we're a small but mighty team, we're all working remotely. And in truth, that's part of our strength. Remote working means that we can connect with incredible talent from across the UK and around the world, helping us push forward faster and smarter. But without a central office, we need flexible, inspiring spaces where we can come together to work productively, collaborate meaningfully, and work on this huge goal we have set ourselves. That's where Colony comes in. Colony is a growing network of beautifully designed co-working spaces here in Manchester, home to creatives, founders, freelancers, and teams of all sizes. They are spaces built for focus, connection, and progress. Not just a place to work, but an environment that actively supports your growth. And they've helped NKMT do just that. To find out more about how Colony could support your business, check the link in the show notes. But I'd love to kind of just go back then to kind of, talk about the risks and who's most at risk, and obviously, what those risk factors are, but also what we can be doing to prevent brain hemorrhages as well. Because I think for this episode, that's what people will be, so interested about. And we spoke earlier, if somebody's had a family member who's had a brain hemorrhage, that's what they're going to really be thinking about. So we've spoken about hypertension, high blood pressure being one of the considerable risks of brain hemorrhage. We've spoken about age as well. But what other risks are there? Do things like ethnicity play a role? Do things like, demographics, income, postcode, any of those play a risk in somebody having a brain hemorrhage? Yeah,
no, absolutely. Because I think, the important thing is that by understanding what risk is, people can then actually get more have changed, do things to reduce risk, obviously. So I think, just to take a step back and go back to what you asked me at the very start, I think, one of the things to be absolutely clear about is that hemorrhage and stroke is a vascular condition. So when I say it's a vascular condition, that means that the primary cause of that disease, i.e. the bleed or the clot, is in the blood vessels. The consequences are what we call neurological. Okay, so therefore its effects on the brain, and I think that's one of the reasons why. Going back to the earlier question you had, Fiona, Ronald's hemorrhage maybe hasn't had the coverage as much because it sort of doesn't follow as a classical neurodegenerative disease, and it sort of sits in this sort of boundary between vascular disease and brain disease. So, and that's important for risk, and that's it's relevant to risk. So basically, the risks are anything that makes your blood vessels not work properly, or be vulnerable to rupture. And risk is true for either a clot or a hemorrhage. If you think about it, if you go back to this analogy, and of course, vascular biologists and people who work on blood vessels will tell me off for saying that they're just pipes. They're not just pipes. They're highly complex cells. But if we just, for the sake of the podcast, think of them as pipes. The key thing is to keep these pipes as healthy as you possibly can, to make them be able to do what they do, which is basically dilate and constrict. So that's basically, vessels open up to allow more blood, or constrict to allow less blood. And so the risks for hemorrhage are related to that vessel and its propensity to rupture. And of course, age we've mentioned already, right? So, but we've mentioned we can't do anything about age, so you can put age to one side. It's a non-modifiable risk factor. You've asked ethnicity as well. So there are certain populations that have higher risk. So Black population and South Asian populations do have higher risk for hemorrhage. That partly may be genetic, but also it's partly risk factor. That in the populations there's higher incidence, for example, of hypertension.
And if I can cut in there, is that they genetically have their predisposition to have hypertension, or is that because culturally their lifestyle would more likely contribute to hypertension?
I will be careful here because I'm not an epidemiologist. I think a combination of both.
Okay.
I think there are undoubtedly some genetic factors which make certain populations more at risk, but lifestyle is undoubtedly a factor as well. And as anything, and it's nothing's black and white in science, and particularly in disease. It's what we call multifactorial. There's several. Yeah. And that's why changing one single thing you may still have a hemorrhage, right? And you say, well, why did I have it? I stopped doing that. That's just what happens. So with high blood pressure, we've talked about a lot. Smoking. So the reality is, and people have had this thrown at them for decades, it's vascular risk. Okay, so your risk of a heart attack and your risk of having problems in your heart is a vascular disease as well. There's not dissimilar risks. So smoking is not good because it obviously affects many things. Diabetes, is a risk as well. So diabetes is a risk, and that's partly because it's associated with hypertension. So these conditions don't sit on their own. They're strongly associated, and we talk a lot now, and we're trying to, and this is proving challenging really, because one of the reasons I think that we don't understand risk as well as we could and manage it probably as well as we could is that medicine is still relatively siloed, I call it. So medicine tends to sit in specialities. So if you've got diabetes, you go to a diabetes clinic, okay? If you've got hypertension, you go to a hypertension clinic and see a hypertensive doctor. The reality is you've got diabetes and hypertension actually, and probably you've got something else. So you've got 3 conditions. So you're what we call multimorbid. You have multiple conditions, and we know this is a real important factor, and we're beginning now to put together research which is tackling that. And it goes back to your point about working together. It's about bringing actually these groups who work in different, to bring them together and talk about commonalities. So smoking, I've mentioned diabetes, drug use, so illicit drug use. So certain illicit drugs will cause, and again, it tends to be linked to blood pressure, that these cause spikes in blood pressure, which can cause hemorrhage. There's also drug use, normal drug use medication. So people who are at risk of a clot will be given drugs which make the blood thinner to allow it to stop. So anticoagulants are called. So these are quite common. So anticoagulants are drugs taken by people who are at risk of having a clot. But actually, if you think, it's quite simple. If you think, go back to the start when I explained this, if your blood's less likely to clot than if you have a bleed, then potentially it's got a slight risk of bleeding. So there is some associated risk with anticoagulant drug use. Of course, slight, I'm going to be careful. Don't stop taking the messaging has to be clear here. The risk of stopping your anticoagulants if you're at risk of clot is really high. So don't do that. And you'll be managed by your doctor. Your doctors are very, very well aware of this risk and will manage it appropriately. So there's a few factors that are risks, but they're not causal. I think the important thing is to get across the fact that it's not causal, i.e., if you have hypertension, it doesn't mean you're 100% going to get a hemorrhage. It means you're at increased risk. So if you manage your hypertension, you're at lower risk. And it's the same as, I don't want to belittle, make it sound trivial. It's like crossing a street, okay? If you go across the Green Man, and across the Green Man, when it's on where you're meant to, your risk of being run down is lower than if you run across the road when traffic's moving.
Yeah.
And that's just managing risk. And that's what we're trying to encourage people to is be aware of risks. So what are the risks and manage them? And of course, we are doing better. So I mentioned incidence of hemorrhage earlier on. So although the mortality of stroke has not changed in several decades, sadly, the incidence of hemorrhages actually looks to be lowering slightly. So the number of people per year having a brain hemorrhage is reducing. On the other hand, the prevalence, and this is the terms we use, so the number of people per year is going down. The number of people who have had a stroke is going up slightly, and that's because of aging, because we have an aged population, so more people are living longer. So therefore, you're just trying to understand that incidence and prevalence. But the incidence is going down, which suggests that actually preventative measures are working. So increase exactly what you're trying to do with the charity is raise awareness of blood pressure, manage blood pressure, stop smoking, take exercise. And if these are, and I know Adam was on it on the last series, we know now, and there's really good evidence that actually, the similar vascular risk factors are contributory towards dementia.
Yeah.
So actually, if you sort of go disease agnostic, as I call it, and not think about what the end condition you might get is, but just think about your overall brain health, actually maintaining good blood flow. So I think and I'm sure Adam said this in his podcast, maintaining good blood flow to your brain is a really good thing to do. And that's about healthy lifestyle, making these blood vessels, these pipes, just keep working as well as they can.
Thank you to our sponsors, Hugh James Solicitors, for supporting this second series of the Prevent the Preventable podcast. Now, sudden brain hemorrhage can turn your world upside down, but discovering it was caused by a medical mistake makes it even more devastating. While nothing can change what's happened, Hugh James's medical negligence team is here to support those who suffered brain injury or bereavement due to medical errors. And their support doesn't end there. The Hugh James Wills and Estate team is also on hand to help you plan for the future with clarity and care, because when the worst happens, the last thing you need is added complexity. To find out more about how they can support you and your loved ones, head to the services page on our website and book a free call with them to discuss your concerns. You can find the link to all of that in our show notes. I think sometimes, and I don't know why, maybe you know the answer to this, Stuart, but I think sometimes we look for the more complicated answer. What can I be doing? And actually, it is just about, and that's what we've tried to do as a charity, is make our prevention campaign as simple as possible. We spoke about aneurysms, and we spoke about, the risk that is posed, or the anxieties that can be caused if you're looking for it, find you have one, etc. What do you do about it? We spoke about age, not a huge amount you can do about that in terms of a risk factor. But actually, high blood pressure is one of those things that actually can be managed. And the majority of the time, it can be managed through lifestyle. It doesn't have to be complicated. Just move more, drink a bit less, stop smoking, all of the things that we're told to do as a health. And actually, when I go into companies and I do what we call a lunch and learn, and I talk to the employees about the importance of blood pressure, its relation to brain hemorrhages. And one slide sort of talks about lifestyle and the contributing factors to blood pressure. And you've got this room full of adults and you're telling them, don't smoke, drink a bit less, sleep well, stress, food, etc. And it feels a bit undermining in a way. But actually, I think sometimes we just need to be clear on, I just need to do the basics and do the basics well. Keep an eye on my blood pressure and, think about it in that way. When we're talking about risk factors, that's probably the best thing that you can do, I'd imagine, to support yourself with regards to, potentially preventing a brain hemorrhage. I don't know whether there is a way to understand this, but do we know how many brain hemorrhages are affected by high blood pressure? Is there a way to kind of, give that a numerical value? Or
so in terms of, I forget. I can't again. So the majority are linked to high blood pressure.
Okay.
Yeah, I mean, so we'll as a risk factor. So I forget the figure. It's probably in the order of 60% or so. So attributed to, again, it's attributed to. It's not absolutely the causal reason, but the risk, that risk factor was there in terms of its contribution. So, and the most important thing is it's modifiable. We talk about this. I mentioned this earlier on: modifiable and unmodifiable things. Unmodifiable things we can't do anything about it by the very term, but of course it's modifiable. Of course, and they'll be in situations where people have got diagnosed with hypertension. They've gone on medication or changed their lifestyle, and their blood pressure becomes normal range, and they have a hemorrhage, and that's it's not absolutely guaranteed that it's not going to happen. There's nothing's certain in life, but it reduces risks, as we mentioned before. And I think you're right. I think I often think to myself, and sometimes you feel like you're telling people again and again the same things. And of course, from a public health point of view, we've known this for decades. Public health messaging, campaigning around diet and exercise, etc. The message has been out there for a long time. And I just, I think what you're doing, and I think going out and talking about it more and just making people aware of it, I think there's a great contribution here from behavioural science. Behavioural science is obviously an element where people, why do people not change? Why do people not change behaviour when actually the data is clear and the evidence? And science is all about evidence. Does the majority of the evidence support this argument? There's no question that the evidence tells you that making your blood vessels unhealthy by poor diet or having high blood pressure is not a good thing to do. So therefore, why don't people change behaviour? And I think that's complex, of course, but I think at least raising awareness that actually just checking your blood, because many people, even myself, I'd never checked my blood pressure till about, actually, my wife had high blood pressure recently. She was diagnosed with high blood pressure, and she got a blood pressure monitor at home, and I checked my blood pressure. It's the first time I checked my blood pressure, I don't know when, since, and thankfully it was okay. But how many people actually have checked their blood pressure in the last year?
Yeah.
Of any age, and I think that's the important thing. It's not saying that you're 75 or where you're at high risk of hemorrhage in your 30s, or because if you're in your 30s with high blood pressure, that the impact of that on later life is, we know that. And in terms of course, risk of hemorrhage, but risk of dementia, etc., there's a good epidemiological data now suggesting if you have midlife hypertension that's unmanaged, your chances of getting dementia are higher.
Yeah, I think it's such an important point that though, Stuart, is that we do know that it is such a risk factor. As a society, hopefully now more people do through some of this work that we're doing. I think there's some common things that stop people from checking their blood pressure at all or regularly. Is one, awareness in the first place, and that education piece around, oh, I didn't know it was so important to check it. I didn't realize it was such a risk factor. The education around, well, I don't really know what the numbers mean. I don't know what I'm checking for. What's high, what's low. Remembering to do it. We're not encouraged to do it in the same way that maybe women are encouraged to check their breasts every month and things. So there has to be more, in my mind, public health campaigns around that. Have you checked your blood pressure recently? And also just like access to monitors. I think people are still scared because it's probably only really recently, reasonably recently, that actually people have been able to check their own blood pressure through, they're more, they're easier now, the blood pressure monitors. You don't have to pump it. Like I remember my grandma was a doctor and she would do that, and that, what if you do that wrong? And I think people worry about that, and I get the wrong readings. And so I think there's an educational piece around showing people that it is easy to do. They can check their own blood pressure, the education around what are they actually checking for, and just reminding them. And that's what we try and do with a lot of the work that we're doing. But I'd be interested to hear what you think. What's one public health campaign or sort of intervention that maybe we need to kind of push this forward a bit more? Because you do see it in the windows of pharmacies, get your blood pressure checked here. And there are sort of, well, now I'm aware of it. I'm very aware of it. So I see it here and there, but I don't think it's pushed in the same way that other things are. So is there something that you feel like that we're missing, that other conditions maybe are doing and we're not, around the subject of hypertension?
Yeah, I think that, I'm not a hypertensive specialist, and relatively recently, obviously through the work that you're doing, there have been campaigns. Undoubtedly, the British Heart Foundation have had a major campaign and still do. I do wonder whether it's where you position that campaign or where you highlight it is important. And I think you're right. Pharmacists have it in their window, but actually, in general, how many people stop and look in a pharmacist's window? Okay, probably not that many, right? I certainly would never stop and look in a pharmacist's window. So I think one way to do it, and we did this. I'm a great advocate of public engagement. I.e., I mentioned this earlier on that scientists aren't necessarily have always been the best at talking about what they do and why they do it. So we've made an actively over the last 2 decades, we've gone out to talk about what we do and engage with the public in terms of public engagement. And I was really conscious to take that to places where you wouldn't expect a scientist to be standing talking about science. A museum, you expect it, because museums are cultural and learning environments, so therefore people would sort of expect to see it. If you're at the Trafford Centre or standing at Piccadilly Station, you don't expect a table of scientists to be standing there talking about the brain. And I think the same thing's true of promoting and making people more aware of blood pressure. Is actually why it should be in places where a large number of the public are and don't expect to see it. Okay, and it's not to make this that everywhere you go you get bombarded by this, because of course that's the wrong. You don't want to over message, because obviously that's dangerous, because actually it's a risk, and not and if you go back to incidents, most people are perfectly healthy and fine. So I think we don't want a scare campaign. You don't want to make it like it's a scare campaign. You've got to manage it appropriately. That it's providing the information, but making people aware that actually, do you know what? Maybe I should just check my blood pressure. And if it's all, and it will be in the majority of cases, it'll be absolutely fine. Then actually, you've got nothing. That's fine. Just check it every so often. Just keep checking it, and actually, it'll probably in the vast majority of people, it will be fine right through their life. But if it isn't fine, and you didn't know it, then actually and you can do something about it. And I think that's the key thing. It's not, you mentioned aneurysms earlier on, and of course, if you have an aneurysm, as we mentioned, you can't do anything about it rather than manage it. But if you have high blood pressure, you can get medication. The medications are really good. Or you change your lifestyle. And actually, a lot of hypertension, and Adam, of course, will have talked about this in detail, and he's a specialist. You can manage it by diet and change your lifestyle. Yeah. And so that's, you have control then, right? So it's actually quite powerful from being able to do that.
I think that's sometimes the hardest message, or the hardest job that I have sometimes. I don't want to scaremonger people, and I don't want to say, you're a massive risk now of having a brain hemorrhage and et cetera, et cetera. But actually, I think it's really important to give particularly adults, information and say to them, these are the risks. This is something that you can do. And to your point, it's most likely fine. But if it's not, then you can do something about it, rather than just let it kind of continue and actually be a problem. So I think that's the message that we kind of try to spread as much as possible. To your point, we don't want to push it, scaremonger people, but I think there's a Swiss cheese effect. We kind of want to, if we miss somebody over here because they don't listen to the podcast, which obviously they should be.
Yeah.
But then we'll hopefully get to speak to them in a company at lunch and learn, or we miss them there, we can get to speak to them through an awareness day. We're looking to speak to kids when they're younger. So, ultimately it's like, how do we layer up these different campaigns that we have around our prevention campaign in total as well? But I think this has given probably people, hopefully it's given a lot of people a lot of information around brain hemorrhages, the causes, what they are, and a really good understanding. Actually, as I said right at the beginning, it can be really complicated, but actually it doesn't have to be. And we can talk about it in quite simple terms, really, unless we're actually going in and treating it. We don't necessarily need to know those ins and outs. But I think the most important thing that hopefully people take away from today is actually what they can do.
Yeah, absolutely.
There's risk factors, but actually what they can do on the back of this as well. So thank you so much, Stuart. And we will share more links and things about where we can find more information about the Jefferson Brain Research Centre and all the research that you're doing in our show notes as well. So thank you.
Great. No, thanks to you, Fiona, and thank you for the great work you're doing.
Yeah.
Thank you.
Well, I feel like I learned so much from Stuart there, and I sincerely hope that you did too. As I said right at the beginning, when we understand more, we can take more action. And that is what this is all about. So thank you so much for joining us for this important and eye-opening start to Series 2 of the Prevent the Preventable podcast. We hope today's conversation has helped make sense of the big picture, the number of people affected by brain hemorrhages, who is most at risk, and what the statistics are really telling us about prevention. A huge thank you to Stuart for sharing his insight and helping us translate complex data into real practical language. And if this episode resonated with you, please consider sharing it. Whether that's with a friend, a family member, or a colleague, conversations like this are how we build awareness and help save lives. And finally, make sure you're subscribed so you don't miss our next episode, where we ask the question, when might you need legal support after a brain hemorrhage? We'll speak to our solicitors from our podcast sponsor, Hugh James, and explore with them the process of medical negligence claims and when they might be needed, as well as the system of wills and probate. That is going to be extremely helpful episode for anyone confused about if they need legal support or not post experience of brain hemorrhage. But until then, thank you for listening, take care, and we'll be back in a couple of weeks for our next episode of the Prevent the Preventable podcast.